So a brief tech check, everything is visible. I'm audible. Is that all right?
Okay.
Yeah. So it's been 100 years since insulin has been invented. And as you can see here, there's a little bit of green color here, somewhat signifying the evergreening of insulin. So over 100 years, insulin has undergone several iterations of refinement. And today we have insulins that act very quickly to produce a spike and offer a lot of flexibility. At the same time, insulins that act very slowly, so much so that there is no peak in their action. What I am going to talk about is those quickies, the kind of prandial insulins that act very fast and bring down the postprandial glucose levels. So this will be the flow of the talk. Uh, we'll talk about PPG control, postprandial glucose control to achieve glycemic targets, why it is important, insulin intensification strategies, a basal plus concept, comparing the prandial insulins, and then we'll look at a few practical considerations as well. Now, since most of you are probably treating diabetes patients, this would be like preaching to the choir. But nevertheless, it is important to realize that insulin is indeed the need of the hour. So with each new oral diabetes agent, there's always this, like the Delphi sword, there's always this question, is insulin going to go out of fashion or is insulin going to be redundant? But that is not really the case. Even after 100 years of insulin discovery, it still is the most important drug in our arsenal to control diabetes patients. Part of this has to do with biology, part of it has to do with the behavior, both from the patients as well as the doctors. Why do we say this? By the time insulin is initiated in Indian patients, the duration of disease is quite long. It's maybe 10 years, maybe 15 years, or even more than that. Secondly, the complications are already present. There is, no matter how much we try to deny it, there is a bit of inertia, both from the clinicians as well as the patients. Consequently, when we initiate insulin, it isn't often the case that insulin is initiated too early, but it is often the case that insulin is initiated later than when it should have been. That is the common situation in India. Now, with that background, we know that insulin is essential and it is started either at the right time or sometimes even later than the right time. And what are we trying to do with the insulin? We are trying to control the glucose. And what kind of glucose? Both fasting and postprandial. But with the short acting or prandial insulins, as the name implies, we are trying to control the postprandial blood glucose. Now, once fasting plasma glucose is controlled, that is, fix the fasting first, disease progression means that many patients will experience progressively worse postprandial glucose control. Their control will sort of um, lose the grip and they will have worse postprandial control. Now, this is an important graph for us to understand. This is a stacked bar graph. As you can see here, when the A1C is really bad, in double digits, above 10%, we can see that the contribution of fasting plasma glucose to that overall glycemic picture is quite high. But as we grow closer and closer and closer to the target, the contribution from fasting becomes less, but the contribution from postprandial glucose correspondingly becomes higher. So in order to go even further than this, optimizing the basal insulin would not be a right choice because that is not the problem. The problem is that there is a high postprandial glucose control, which is driven by a variety of factors, including our carbohydrate rich diet and so on. But nevertheless, it's important to realize that PPG becomes a big target as we go closer and closer to our desired HbA1c levels. Now, if PPG is such a big target, and why are we not able to achieve it in some patients? The reasons are many. Some of these are rather generic reasons as to why patients wouldn't like to take insulin itself. Some of these are specific. So, too busy, traveling, skipping a meal, these are specific for prandial insulins because a basal insulin can be taken in the night when all the work is done and the patient is about to sleep and there's nothing to disturb him. On the other hand, prandial insulins have to be taken before a meal, and it may not, the environment may not be suitable or conducive to take an insulin. It can also be a source of embarrassment and in certain places even discrimination when a person is carrying an injectable insulin. It is also challenging to adhere to timing of injections, and quite frankly, some people may forget it because of life gets in the way. So there are lots of barriers which stand in the way of PPG control and uh, good HbA1c control. Now, one way to solve all of these problems is to have flexibility of insulin injection. What do I mean by flexibility? In the past, the prandial insulin or the regular insulin had to be given roughly 38 minutes before taking any food. Now, that meant that people had to meticulously plan the food intake, design their life around the insulin, which is not what we are trying to do. What we are trying to do is to design an insulin around the patient's lifestyle so that it can fit into any lifestyle, any flexibility that is required for the patient. And that means we need an insulin that uh, goes in quickly, does the job, and gets out of the system quickly. Somewhat similar to a surgical strike. We need an insulin that starts acting very fast, controls the PPG, and then gets out of the way as soon as possible. And that is where the newer prandial insulins come into play. What is the insulin intensification strategy? Intensification strategy is if a patient is started on basal insulin, and after a period of time, if the A1C is not controlled enough, in spite of having good fasting plasma glucose, then we know that the time has come to add a prandial insulin, and that's what we mean by intensification with prandial insulin. And ADA 2021 recommends flexible insulin intensification. Actually, we do not need the ADA to tell us this common sense thing. Any insulin intensification needs to be flexible and acceptable to the patient. And it's more of a two-way between the doctor and the patient where we decide on what is possible. And like politics, insulin initiation is at the art of the possible, whatever is working in a given scenario for the patient. Now, as I said before, we start off with lifestyle changes plus one drug after the other, oral drugs, three or more oral drugs. Then we go with basal insulin and then add a prandial insulin to the main meal. Main meal meaning the meal with the largest postprandial glucose excursion or the largest meal, whichever is applicable. And finally, the highest complex kind of insulin regimen is the basal bolus regimen. So basal plus is in between complexity between basal insulin, which is the simplest type of insulin that can be used, and the industrial strength basal bolus regimen. So this is somewhat of a compromise between complexity and flexibility. So what is basal plus? Some meals tend to have a bigger impact on postprandial glucose, and that meal can be covered with a short dose of insulin, and that's called the basal plus regimen. And what kind of insulin we can use to target these large meals will ultimately depend on the action profiles of different insulins. Now, this is one graph which shows the different action profiles of insulins. So insulins can range from quick onset, quick offset action, which is the ultra rapid acting insulins, to very, very slow onset of action and almost a never ending no peak insulin like insulin degludec. So between these two extremes lie a variety of insulins. Almost all insulins can be put into one basket or the other. And it is important to know the action profile of different insulins that we use so that we will know when to give that insulin, when that insulin will start acting, when it will have peak action, and how long it will act. So onset of action, peak action, and duration of action, all these three things put together in a graphical format is what we call as action profile of different insulins. And it is important for the clinician to know each insulin's action profile so that we can tailor it to the patient's life. And there are also ethnic differences in insulin sensitivity and postprandial glucose. Indians have a tendency towards higher postprandial glucose concentrations. It is partly driven by our diet, partly driven by our genetics. The diet we can do something about. The genetics, we can't become Caucasian. So there's little we can do about that. So the only thing that we can do are two things: the carbohydrate or the simple carbohydrate content in the meal, and the kind of drug that we are taking to control postprandial glucose. The easiest in this situation would be a postprandial or prandial insulin. A single dose of prandial insulin will cover major contributor of PPG in most flexible and physiological way. Now, at this point, we must realize that no insulin can be 100% physiological because we can't inject it into the portal circulation. But apart from that tiny glitch, the fastest insulins that we have solve majority of the problems. And instead of searching for the best solution that is possible, we are sometimes able to choose the good enough solution for majority of our patients. So next we come to what prandial insulins are there on the menu card and how they compare with each other. Now, in order to understand why a prandial insulin or a new and shiny prandial insulin is required, we need to realize the limitations of regular insulin, the good old regular insulin. It has a delayed onset of action between 30 to 60 minutes, peaks by 2 to 4 hours, and may lead to early postprandial hyperglycemia and late hypoglycemia. Now, this undesirable properties of regular insulin need to be removed in order for us to have more flexibility. And that is done by making small changes to the structure of the insulin. Insulin Lispro was the first introduced analog prandial insulin. The main purpose of changing the structure of this insulin slightly bit is to reduce the tendency to form dimers and hexamers. Once we inject insulin into the system, into the subcutaneous space, it forms dimers and hexamers and then slowly releases the monomers, and then that monomers go and act. But if it forms a lot of hexamers, then it's going to delay the onset of action. So one way to do that is to change the the geometry or the structure a little bit so that it doesn't form dimers and hexamers. And all short or ultra rapid acting insulins work in exactly the same way with tiny differences between them. Now, this increases the rate of absorption into the system so that the patient doesn't have to wait patiently for the insulin to start acting. So insulin Lispro is more physiological, it's faster, it can be given much closer to the meal, thereby reducing the chances that the patient may have to skip the meal or cause some hypoglycemia or anything like that. These are the benefits of rapid acting analogs: faster onset, less risk of late postprandial hypoglycemia, because just like it is fast on, it is also fast off. As a result, there is very less risk of late postprandial hypoglycemia. And it gives a better mealtime flexibility because it can be given closer to a meal. The newer things like Fiasp can be given even just after the meal, and thereby it gives the ultimate mealtime flexibility for any kind of lifestyle. Are all rapid acting analogs the same, or is there a difference? To be very honest with you, the differences are more in terms of their structure and pharmacokinetics and nice looking photos like this than in a real world. Nevertheless, it's important for us to know the small differences between these insulins. There have never been any head-to-head three-way comparisons of these insulins like Lispro, Aspart, or Glulysin. Consequently, we are made to pick up the pieces from different sources and then try to form a gestalt from whatever is published in different trials. And from that data, what we can see is that Glulysin is the only zinc-free insulin. So how does it matter, and why should I care about zinc-freeness of an insulin? It really doesn't matter that much, but it does have a polysorbate 20 instead of zinc, which apparently maintains a fast rate of dissociation into monomers. So it has a faster onset of action than Aspart, slightly faster onset of action. This means that we can give the insulin much closer to the meal and thereby reducing the risk of late postprandial hypoglycemia as well. Now, this faster onset of action also means that the 1 hour post meal in obese subjects with type 2 diabetes would be slightly better with insulin Glulysin than with Aspart, as you can see here in this graph. So you have to use a magnifying glass to see the later portion to be different, because they are all almost the same, but there's a tiny bit of difference at 40 to 60 minutes. Switching to glulysin also results in increased glycemic control for minimal safety levels. But there, apart from these three things, that is glulysin, aspart, and lispro, the canonical fast-acting insulins. Nowadays, we also have the Fiasp, which is available in India, and there's one more insulin called Lumj, which is not yet available in India. Fiasp is a fast-acting aspart, Lumj is a fast-acting lispro, and they have Fiasp contains some tiny modification to aspart so that it can act very fast within the minute of injection of the insulin. So what are the practical considerations? The most important practical consideration is to avoid over basalization and start prandial insulin as and when it is required. When do we know that the prandial insulin is required? When A1C target is not achieved with half a unit per kg per day of basal insulin. That means the patient is not requiring just basal insulin, but something more, and that something is usually a prandial insulin. When the patient has normal FPG, but still A1C is not under control, it automatically means that the postprandial is spiking, and we need something to control that. Then targeted PPG levels with basal insulin can be a problematic thing, because basal insulin isn't, of course, it can to some extent control the PPG as well, because the FPG and PPG are not happening in a vacuum. They all happen in the same patient. But the purpose of a basal insulin is not to target PPG. So in any situation where the total basal requirement is more than half a unit per kg, or A1C levels are uncontrolled even after FPG is controlled, that's a time for us to stop titrating basal and add a prandial insulin. So the mealtime insulin may begin with one of the methods. We can either give 10% of the basal dose, 4 to 6 units administered with the largest meal per day, or a dose based on the patient's weight, or dose defined based on levels of PPG. So we can use any of these methods. These methods are not, again, head-to-head compared with each other. Whatever is working for a given situation, we can use. So a fixed thing like 4 to 6 units or 10% of the basal dose is quite easy to follow, because it's easier to calculate than dealing with double-digit decimal numbers like 0.05 or into 2 divided by 18 into 2. That just makes more of a mathematical headache for us than the simple numbers of starting with 4 to 6 or 10%. So any method can be used. The best thing to remember is that over basalization has to be avoided, and prandial insulin has to be started as early as possible. So here are some advantages of glulysin. It's faster absorbed, onset of action is fast, duration of peak action is quick, and window of flexibility of dosing is also better with glulysin. But some of these data come from the manufacturer's own internal studies, and not much head-to-head comparison. So we may have to take it with a pinch of salt, but it is, of course, a quick-acting insulin that works to have very quick onset of action and offset of action. So to sum up today's talk, diabetes by its very nature is progressive, and it may result in progressive worsening of glycemic control, predominantly driven by the postprandial hyperglycemia. And in order to address that postprandial hyperglycemia, we would need a rapid-acting analog in the background of a well-adjusted basal therapy, and stepwise intensification of basal insulin with a single dose of prandial insulin. The so-called basal plus approach is very easy to follow, because it's quite simple. There's going to be just 2 pricks for the patient. And among the rapid-acting insulins, glulysin offers a slightly earlier onset of action, slightly greater PPG reduction, and a maximum window of flexibility. And therefore, it can also be considered as one of the rapid-acting insulin analogs. But to be very frank with you, we would be hair splitting if we have to choose between any of the 4 available fast-acting insulins in India. And in a given patient, the difference between them is likely to be very minimal for practical usage. And the only important difference is whether we are able to convince the patient to take that second shot of prandial insulin. So thank you so much for listening. It's been wonderful talking to you all. Thank you so much.
Thank you.
Okay.
Please.
Thank you, Dr. Balachandran, for very lucid and elaborate presentation. Thank you. Now it is the time for a question answer sessions.
Yes. So we have few questions from audience. The first question we can see in the chat box is, does the quantity and quality of food should also result in dosage variation of prandial insulin rather than a fixed dose?
Yes, if a patient, much of the postprandial glycemia is driven by simple carbohydrate and to some extent the protein also. So the quantity of protein and carbohydrate in the diet basically leads to the postprandial hyperglycemia. And if we are able to address that, then that can result in change in postprandial hyperglycemia and subsequently change in prandial insulin as well. In fact, whenever we see a patient with postprandial hyperglycemia, we need to have a simple conceptual approach. Why is the patient having postprandial hyperglycemia in the first place? Is it what can we do about it? We can reduce, for instance, the carbohydrate in the diet, or we can slow the absorption of carbohydrate by adding fiber to that diet, or we can reduce the carbohydrate and replace it with protein which has moderate impact, or fat which has impact on the 2-hour post. So dietary approaches we can do. Next, once the food gets into the GI tract, we can delay the absorption of carbohydrate by adding an absorption delay agent like alpha glucose disinhibitors. And then the glucose gets into the system. Once it gets into the system, we can reduce it by a variety of ways. One is to increase the insulin that is available, either by using an insulin secretagogue or by using the prandial insulin. So these are the broad conceptual approaches we need to have, and each point in the pathway, from the way the food is made to the glucose spike after eating it, is a potential step where we can intervene and control the glucose. So as the audience person has asked, it is important not only about the quantity and quality of food, but a variety of other factors which are to be taken into account whenever we are thinking of prandial insulin.
So beautifully answered, Dr. Karthik. I think we can also add something that the concept of carb counting and the insulin sensitivity index, so that we usually practice in type 1 diabetes. Again, for some insulinopenic type 2 diabetes, that can be helpful as well. So I was wondering about one thing, Dr. Karthik, that whenever we read about ADA guideline, they always tell us for the peak postprandial glycemic target, which is not obviously the 2-hour target. It's somewhere between 1 to 1.5 hours. But in our clinical practice, we always do a 2-hour postprandial blood growth, at least in India. So what is your take on this?
Yeah, the 1-hour glucose is generally likely to be higher than the 2-hour glucose. One advantage of using this quick-acting insulins is that we might be able to target the 1-hour glucose as opposed to the 2-hour glucose, and that is because it can act quite fast without the risk of late postprandial hypoglycemia. If we have to target 1-hour glucose with, say, a old regular insulin, we might still be able to do that by increasing the dose, but at the cost of late postprandial hypoglycemia. The common argument against this is that the old regular insulin might give some degree of cover for the intermeal snacking, which is very common in Indian subjects. But in reality, what we see is that the intermeal snacking leads to a spike that is often not well covered by the old regular insulin. So by shifting to a very quick acting insulin, we may be able to target the 1-hour glucose, and if it is controlled, naturally the downstream 2-hour glucose will be controlled, and without the risk of late postprandial hypoglycemia, because the insulin would have stopped acting after a couple of hours. So I think the kind of insulin we choose will also be an important factor as to what 1 hour, 1.5 hours, or 2 hours that we can target.
So, absolutely. One last question that I can see that what is your choice for prandial insulin when patient has diabetic gastroparesis?
If I would choose the fastest acting insulin, which is currently there in our country, and that would be Fias, but with the caveat that these insulins have not been tested one against the other. So one is the speed of action, flexibility of action, and the second thing would be the cost of the insulin. So with these two major factors in mind, I would probably go with Fiasp or any of the other insulins, whichever is applicable. In our place, there's a sort of reimbursement system for different kinds of patients who come here. So that also in some cases influences the choice. But if money is not an issue, I would go with the fastest insulin available.
All right.
One question, Dr. Balachandran. What is the prospect and efficacy of prandial insulin, which is given by inhalation, like Exubera or Afrezza, particularly for the patients who have needle phobia?
Okay, so if needle phobia is there, then possibly the Afrezza or Exubera can be given. But as we know, it is not available in this country. We do not have a sort of practical experience with it. But I guess that should be an option. The other thing, if a patient has needle phobia, given that we do not have inhaled insulins in our country, is to use something called an eye port, which is quite expensive. By the way, it's about $800, but it can stay in there for a couple of days or 3 days, so that it creates a kind of subcutaneous port, somewhat similar to an infusion pump, but with no pump is there. And we simply inject the insulin into that. So the patient doesn't feel the prick. It's there for a few days. And it is, and the needle is not seen by the patient, thereby not exacerbating the needle phobia. At the moment, we do not have inhaled insulins in the country. Neither do we have that Lumjave. And we also don't have the very long acting icodec. So with whatever we have, we should be able to give either an iPort or better education to the patient, so that we will be able to control the postprandial glucose.
Thank you. Thank you.
So I think I thank Dr. Karthik for this nice elaboration and the interesting question answer session. I see no other question in the chat box. I think the other question is already answered. So thank you for participating as a speaker. With
Thank
this,
you, Dr. Subhadip.
with this, I conclude the session and hand over to the organizers.
Thank
Dr.
you. Thank you.
Thank you. Thank you.